Great. So I have the privilege today of introducing Professor Sir Mark Caulfield, Professor of Clinical Pharmacology at Queen Mary's University of London. He's going to be delivering today's Association of Physicians Early Career Researcher webinar on how to plan your research, covering the necessary attributes for a successful academic career. Any Google search will quickly show you that this is a man who's assumed many roles. Vice Principal for Health at the Faculty of Medicine at Dentistry at Queen Mary's, outgoing President-elect of the British Pharmacological Society, Director of the William Harvey Research Institute, and Chief Scientist for Genomics England from 2013 to 2021. So, since graduating from the London Hospital Medical College in 1984, he's faced many academic challenges. His early work leading the BRIGHT study identified novel genes contributing to the development of essential hypertension, and subsequently, his work leading the 100,000 Genomes Project and co-curating the National Genomic Test Directory have been instrumental in driving genetic care into the NHS. So, yes, Professor Caulfield is very well placed to provide advice to us early career researchers. But I can attest personally, having just started off in academia as his PhD supervisee, that his words have meant an awful lot to me in providing motivation and purpose. You'll soon see what I mean. Thank you very much for joining us, Professor Caulfield, and for giving today's talk.
It's a privilege to be here. I am a member of the Association of Physicians, so it's a real joy to be here and share with you my thoughts on research leadership. So, a career in research at junior level, early career researcher, either at PhD or immediately after clinical fellowship, when you might be hoping to become a clinician scientist, is a daunting career path, and many feel that it is too overwhelming. What I'm going to try and do is chart some do's and don'ts and maybe suggest how people could approach thinking about this so they maximize their success. So, why is this important right now that we become researchers, our educators, and become academics? Well, what this diagram shows is that in the 10 years from 2012 to 2022, there was 189 full-time equivalent posts lost from clinical academia. And the majority of those were at senior lecturer or reader level, which is a reduction of 24%. There were slightly more clinical lecturers, probably due to the National Institute for Health Research, and slightly more professors. So, what this is describing is an aging clinical academic community where people are being promoted through the grades, but we're not adequately refilling at clinical senior lecturer or reader level. So, if we don't do that, the consequence of that would be that clinical research could be harmed. We could reduce our clinical research base in the UK. So, I just want to think about some essential points about how we go about this. What are the essential skills? So, to be a good researcher, communication is really, really, really important. Clearly articulating your vision, providing constructive feedback to those who are studying with you, but also those who are your peers and to others who you might meet at international or national meetings. And actively listening are fundamental skills. Now, the good news is that many of those are fundamental skills of being a doctor. So, actually, clarity, constructive feedback, and listening are really what we do every day. So these are things one should not worry about. They are skills that you will have built in some measure. Then the next skill you need is critical thinking, the ability to analyze situations. And again, the scenario that we find ourselves in clinicians, as clinicians, where we're making decisions that we hope are clinically sound on the basis of the balance of probabilities. In other words, you might have a differential diagnosis, but on the balance of probabilities, one of those things is the most likely situation. That also equips us well to be analytical in a research context and to solve problems. And that really fundamentally is a cornerstone of leadership. So as you grow in your career, your ability to make sound decisions and to choose the right path in research or education will help you to become better leaders. Another area that's important is delegation. And we see this also in medicine because everything we do in medicine relies on a team. Well, research is really no different. And trusting and empowering team members by delegating responsibilities is key to an efficient workflow and team development. So the other thing that's important is conflict management. Resolving disagreements quickly within a team is vital for maintaining a productive environment, but it's also absolutely vital in the research space. Now, most research that we do today is multidisciplinary or relies upon other members of the team that may not be us. And so we have to have a good and constructive relationship and the ability to resolve conflict. Adaptability is really, really important. Research leaders of the future must be flexible and agile in response to changing circumstances and challenges. The unexpected result of an experiment which appears possibly on the surface to have failed. And then you must go in and troubleshoot and work out exactly how and where that experiment didn't work and how you would do it differently to make sure it works in the future. So, what other characteristics do you need? Well, the first and foremost is integrity, being honest, ethical, and accountable. Again, skills that we all have as doctors, which build trust within our team, are so, so important. Empathy is also important, understanding and considering the feelings and perspectives of others. This is crucial for building the strength of relationships and a supportive team environment because at times doing research is hard when experiments don't work, when you're not sure why something isn't working. You need your colleagues to help you with the troubleshooting, and you also need to be self-aware. So knowing where your strengths lie and what your weaknesses are. And my advice is to collaborate to resolve your weaknesses and to establish learning collaboratives where you can learn how to address any weaknesses you have, but also you can gain skills rapidly from another person. You also need to have the emotional approach that allows you to manage yourself and your interactions effectively. Sometimes research is a roller coaster where actually you really think something should have worked, you just don't know why it hasn't. But more importantly, you have to pick yourself up and carry on. So research is not always an upward trajectory, it's an oscillating baseline where you and I may be exposed to the risk of disappointment. And being able to do disappointment well is a key characteristic of a researcher. I sort of think about it a bit like a bradycardic ECG. So you've got this basal state where things are not working, there's nothing to be excited about, and then occasionally there's a QRS complex, and that's your peak of ecstasy when you've actually found something that you can publish. So if you think about it like that, you are able to sort of conceptualize how you'll approach that. Being motivated and enthusiastic is vital. You've got to be really passionate for what you're doing and have a really positive attitude that can inspire and energize your team to achieve their goals, but also can inspire them to help you achieve your goals. The positivity with which you approach research, even when it is sometimes difficult, it will characterize your success. Having a vision is important. So the thing that I would emphasize here is when we are clinicians and we go to a clinic, we don't have to make the clinic happen other than enact the clinic. The patients will turn up. People will get the patients ready to come and see you sometimes, and then they come and see you, and you have a discussion with them and maybe examine them, and then you come to a differential diagnosis and conclusion about what you're going to do. That means that when we arrive in the research arena, because our work turns up every day, we're not always attuned to having to make the running. And so the capacity to think long term, set your clear, compelling direction, and make research happen is a real future hallmark of effective leadership. Now, sometimes when colleagues start in clinical research, they turn up on day one and they say to you, well, what am I going to do now? And I will frequently say, well, you've got your hypothesis for your PhD. You need to think about how you're going to enact things and then come back and tell me how you're going to make the running. Because if I keep telling people what to do, all that will happen is they won't develop the skills to think long term. Resilience is also vital. This is the ability to bounce back from setbacks and maintain optimism and composure during difficult times. And this is really an essential feature of success. So, during a PhD or a clinician scientist role, the future direction isn't always clear. So, it's not always clear. But curiosity is vital. You need to form a clear and cunning plan for what you want to do, but that doesn't need to be done alone. The people around you in a group, or even you can source help from outside your group, will help you to define how you go forward. Choose early as you can, a program, PhD, or a career direction that excites you, and plot several routes to that goal because inevitably some of the things you choose to do may not work. So, really important when you propose a grant is not to include a sudden death experiment. So, let me describe what I mean by that. If you have three aims, aim one is you're going to do an experiment, and if that aim one doesn't work, then aim two and three are effectively dead because they're entirely dependent on aim one working. So, because of that, you need to build a system which is it works together as a whole, and you can tell the story, describe your hypothesis and what you're going to do, the plan of investigation, but that you have several routes to your goal so that you do not close off any avenues and that aim one doesn't sink your proposition. Also, be really clear in yourself why you're hungry for this to succeed. Why are you doing this? It almost certainly isn't a stamp collecting exercise for here's a PhD. This is about whether your life course will be altered by it. And being hungry for that success will define whether research is for you or not. Now, when you're driving research, and could be a PhD or it could be your clinician scientist, it's really, really, really important to make sure you are operating at the leading edge of your area. Find out who the leaders are, but more importantly, find out what their human rights record is. Will they look after you? Will they take care of you? Where do their fellows end up? If no one's ever heard of their fellows, they're probably not the person to do your fellowship with. So be really careful about who you choose as your supervisor, because on this journey, someone who's compassionate and caring and wants your success to be as important as their success, and most people of my vintage now, we're living to help others be successful because we've enjoyed great good fortune and it's our time in life to put things back. So whether I was talking the other evening to the president of the Academy of Medical Sciences, he said to me, I'm over 60 now, and my role in life is to make others' lives better. Now, you might say that's been his role all his life as a doctor, but actually in research and in inspiring academic careers, this is a fundamental thing that we need to do. So look after everyone around you. Also get a mentor. A mentor is not a supervisor, and a supervisor you also need. In fact, what you need is two supervisors, a primary and secondary supervisor as a minimum, and a mentor who is somebody who's not the supervisor, not immediately connected to the project, but who will be a sounding board for you, a third party advisor, if you like. Before you submit your grant, nowadays you have to have some pilot data. So you'll have to find a way of either with your supervisor's help or you perhaps committing some time to generate some pilot data. This provides the conviction to the research grants panel that you actually could do these experiments because it's data you've generated or your supervisor has generated, which support the hypothesis that you're putting forward. In research, being organized and disciplined is really important. It's a little like my clinic analogy earlier. The difference being if you don't make the running every day, nothing happens. Timing also isn't everything. If something doesn't go to plan, it is not the end of the earth. You need to stand back, survey each step, work out where something could have gone wrong and what the potential solutions are. You need to be resilient and persistent and have clear plan A's, B's, and C's because quite often elements of plan A won't work, but elements of B and C will help you to come up with a really important piece of research. So, because we're doing research and we don't know what the answer to the question is, because we wouldn't be doing it otherwise, we need to have multiple plans to try and answer the question so that we insulate ourselves against the risk that one plan doesn't work in its entirety. So I had a medical school head who liked this website, which I think is called something like Desperation. And so one of the characteristics that I really wanted to use this image to emphasize is not a man chasing a woman, it is persistence, because persistence is one of the most important characteristics you need. Persistence is so important because sometimes at first you don't succeed, but you've got to keep going. And there've been a number of times in my life where I thought, I can't get this experiment to work. This isn't for me. Maybe I should stop doing it. But actually, you know what? Persistence pays off. The best researchers are the most resilient and persistent. So let's talk a little bit about different types of funding scheme. So what do the research funders fund? Well, the main ones that we might be interested in would be the British Heart Foundation. They have some clinical training fellowships which you can apply for individually. The MRC has clinical training fellowships, and NIHR has both PhD, clinical PhDs, and clinical fellowships. The Wellcome Trust funds doctoral training programs, and we have one at Queen Mary, which is health in underrepresented and underserved communities. It's called HARP, and that has funded 30 medics and allied health professionals over the last few years to do a clinical PhD. And then there's some other charities that may be facing specific diseases or organs, and the European Union. There also are now schemes that are harmonized, particularly across the British Heart Foundation and the Wellcome. And that means you can go all the way from MBBS PhD, so MB PhD program, to chair with a single funder or senior fellow. Let me just acknowledge that the university sector is currently under financial pressure. And we at Queen Mary have a policy that if you get a substantive fellowship, which you hold at Queen Mary via NIHR or some other route, we will offer you tenure at the end of that, subject to your performance. So this is one of the policies that we have to address the clinical academic lack of capacity that we're facing. So if you do get a very successful fellowship and you're clearly going to be successful, particularly at clinician scientist level, we will give you a clinical senior lectureship and an indefinite contract. Because the best thing to do is to grow your own and retain your own. So the big feature that you really, really need, and even some of the funders now say it, like UKRI and MRC, we want you to have curiosity-driven research. But remember that in curiosity-driven research, you will probably come up with things that don't work. A little like this poor, unfortunate penguin, who may be about to discover somewhere that he wish he hadn't. So what I want to emphasize to you here is that curiosity is vital, but curiosity can take you down a blind alley or even somewhere even more unpleasant. So pay attention to the funder's terms and conditions. And it's really, really important that you do. It's important that for resubmissions to funders, which you can do, you include unedited feedback and a detailed response in the revised application. But for all applications, whether they're the first time or subsequent times, most funders use this structure of a title and an abstract, a background to the project and the pilot data. You need an original hypothesis, and you need to provide experimental details and design of the proposed investigation. If you're doing a clinical study, use clinical study guidelines for interventional studies or observational studies. And don't forget to include power calculations and statistical methodology. So the reviewers will look to see that your study is appropriately powered to detect a difference. If it isn't, they won't fund it, and that you're using appropriate methodologies. Just to highlight a particular point, to make sure that design and methodology is really of the highest level, a number of funders like the NIHR, BHF, and also MRC will insist that you use a registered clinical trials unit, which is expert in design and methodology. You're also going to need to describe the expected value of results. And some of you may not know this, but the MRC has just announced a 3-month pause on grants because it wants to realign some of its schemes to show the government that MRC funded research can be a generation of growth and can lead to growth of the UK. So the expected value of results will now need to include statements on growth. Obviously, you need to use a list of relevant references and relevant publications that show that your supervisor is a credible person, although some of these will usually be in the supervisor's CV, which you will submit alongside your own. So the important statements relate to some of the components of the training program. So with you as individual candidates for clinical PhDs or clinician scientists, we need to be able to state the scientific techniques in which the student or candidate will be trained. The candidate's training program will need to list generic and transferable skills that will be acquired during the grant. And sometimes you have to upload additional documents to support these. You'll have to submit your full CV. You'll need support letters from collaborators and possibly intellectual property agreements for how you'll handle any IP that might come out of it. And if relevant, some funders would like to see that you've got ethical approval up front for doing the work before they commit to fund it. Part funding some clinical research training ships full of fellowships with industry is possible, particularly with BHF, especially if it's doing experimental medicine. So just to get this out there, you will make mistakes. Everyone makes mistakes, and you know that from the clinical world that you operate in. But we make mistakes in research too. I don't want you to become the person described here, where it could be the purpose of our lives is to serve as a warning to others. I want you to take your mistakes in your stride, analyze where things went wrong, troubleshoot, do it with other people, collaborate to secure a clear path forward, and then you will succeed and triumph. So when you're applying, things to do, read the guide to applicants. You'd be surprised how many people will bring you something to read and you say, well, this doesn't look like an application to the BHF. And they say, oh, well, I just sort of pulled something together that I thought of. But reading the guide to applicants and adhering to the requests there is very important. Follow it completely. Do authentic public patient involvement and engagement. Now, so by that I mean use PPIE structures that will exist within your centre, hospital, or university, and really ask patients before, during, and after that what you want what they think of it. You'd be surprised how many times patients will tell you that their priority is different from yours, and what you think is really important to them is not important in the same way. With fellowships, you can apply with the same fellowship to multiple funders, but not with other grants such as project and program grants. Again, the eyes of others are very important here. Test your application with others. That's why being in a supportive group environment is really important. Prepare for any interview with multiple practice interviews. If you're rejected, this is the rich tapestry of research. Pull yourself up, talk to others about what the feedback shows, and then go back in and reapply, because that's what you have to do to be a successful researcher. So here I've got some things not to do, and I'm sure you won't do them. But if you don't follow the guide to the applicants and you don't answer the questions, you can't win the funding. Avoid sudden death experiments. I've described a scenario earlier where aim one, if it doesn't work, kills the whole of the rest of the proposal. Don't let yourself get into that situation. If you fail to involve patients in a study that's clinical, it will go down very badly with the panel. And don't put your eggs all in one basket. So if you can apply to multiple funders, apply to multiple funders. Don't just choose one funder and wait for the outcome, because you need to hedge your bets. Do not do the application without any input from anyone else. Don't fail to prepare for the interview. You'll be all right. That's not going to happen if you don't prepare. You can't anticipate some of the questions. And when you have your fully completed application, go through it yourself and ask, if I was reading this sentence, what question would I want to ask me? And you'll end up with a list of perhaps 20 or 30 questions. If you write short answers to all of those, mostly you will get those questions because the reviewers are thinking the same way. And that's why practice interview is really, really important. Do not fail to learn from rejection. Rejection is not permanent for most people. It is a temporary pit stop on the journey to success. And do not ever give up at the first sign of failure. All of us get things wrong for the reasons I've said. So, just to say a little bit about grant schemes that you might be applying to. So, there are project grants, particularly with the BHF. Project grants are up to 500,000. Special project grants are again up to 500,000. And then program grants are longer, £1 to £2 million grants. And then there are clinical study grants. So, for example, in my world, the BHF funded the British Hypertension, British and Irish Hypertension Society pathway studies, which answered several crucial questions. The BHF spends about 108 million a year on research, so this is quite a good source for those of you who are cardiovascular inclined. The welcome is a tricky strategy. It spends a very substantial amount of money every year, but it's not easy to work out their strategy. But if you've got a good welcome career development award for a mid-career person, it might be up to 8 years. It would be, I think it's up to 2.5 million. That is wrong. And this can give you a salary, it can give you funding for a group and the formation of a group for up to 8 years. And then you've got Welcome Discovery Awards that are up to 3 million over 8 years, 3.5 million. With the MRC has 800 million to spend a year on discovery and mechanistic research. It's really important to understand how these funders differ. Welcome does discovery and some degree of implementation research. MRC does mechanistic, and NIHR does translational and implementation research. So MRC does research grants, projects or programs. They do new investigator grants. They also fund their postdoctoral researchers, lecturers, or early career training fellowships. And there's an MRC Skills Development Fellowship and an MRC Clinical Training Fellowship. So NIHR have 1.38 billion to disperse, and they fund fellowships at every career level like the BHF, including nurses and allied health professionals. And that goes from translational bench to bedside research, which might be experimental medicine or early phase clinical trials, to applied implementation research, later phase, direct into patients that is transformative in the NHS. And they also have infrastructure that can fund fellowships called biomedical research centres, applied research collaboratives, and clinical research collaboratives, and research delivery networks that are both in general and also commercially focused. So the European Research Council is another place which we don't go to in the UK enough because of a strange vote that we did back in 2016, which I can't really explain to any of you. So what we have here is a starting grant, which would be for people within 2 and 7 years of experience since completion of a PhD. And you can apply for a reasonable sum of money there, up to 1.5 million for 5 years and an additional 1 million in infrastructure. This is euros, so obviously not quite as much in sterling. You can also, as you become more senior, apply for consolidator grants between 7 to 12 years since your PhD. And the date since your PhD is a successful PhD viva defense date. Um, and the research must be in a public or private research institute or organization. And there must be a single PI to submit the application on behalf of their host institution. And you don't have to be employed at the host institution. Now, ladies and gentlemen, I just want to tell you, we don't compete for this enough in the UK, and we should really change the way we do this. And we are certainly changing this with the absence of MRC money for a period of time. We're going to put in more of these ERC applications. So one of the things that characterizes a good researcher is the ability to make good judgment, unlike this gentleman here. And the good judgment that you make at various different points in your career will signpost and highlight the journey that you need to go on in the future. Try and stop and think about things and pause and ask yourself the question, is what I'm thinking about this logical? Does it sound scientifically sound? If I was told this and I'd never heard this before, would I believe it? So use good judgment because your career will depend on it. And finally, your accomplishments need careful evaluation. Sometimes appearances when you get a set of data may be deceptive. Obviously, you will have heard of some people don't believe that man ever went to the moon, and would prefer to think this was all filmed in a film studio. But actually, the skepticism that you and I have about the work that we do and the self-criticism is crucial to avoid making mistakes. And to try and minimize those mistakes, make sure your accomplishments do you the credit that you fundamentally deserve. So this whistle-stop tour through research and how to approach it, I hope has been helpful to you tonight. And I thank the Association of Physicians of Great Britain and you, Jack and Helen, for inviting me to speak about this. Thank you very much.
Fantastic. Thank you so much.
Yeah, that's wonderful. Thank you so much. Are you happy for me to ask a few questions following on from the presentation?
Definitely. No worries.
Thank you. So one of the challenges, I suppose, that we have as early career researchers is planning what our research is going to look like. I suppose we're towards the end of January now, but still, if we say this is the start of the year, do you make a plan for what your research year would look like? How would you set that out? Do you think that we should be looking to plan over a year, over a 5 to 10 year vision? How would you go about that? What do you think we should? Yeah, I'd be interested to know how you.
It's a really good question, Helen. So when you submit one of these fellowships, either for a clinical PhD or clinician scientist level, you have to submit a plan. So normally you will submit some form of chart, usually called a Gantt chart, which milestones what experiments you're going to do when and what your outcomes will be. So you have a clear guide, a rubric by which you're going to try and operate. Otherwise, what you can find is that you run out of time. The other thing, just to say, is it's not unusual to get to 18 months without any usable data. Okay. And this causes panic. Don't panic. Just knuckle down and be resolved. Sometimes it takes a while of discovering what doesn't work to work out what will work and to make it work. So, quite a lot of PhD students would tell you that the majority of their data is gathered in the last year and a bit, and it's a bit stressful as a result. And I always tell any of the PhD students, let's get a plan together. Let's look at the interdependencies and then look at how you would complete that and milestone it. So even today, I would do that, and I would try and set timelines. Of course, one of the things about doing research is you never quite know whether things will work. And when they don't work, it takes you longer than you expected. So you have to budget in some time for experimental failure and not get dismayed by it, but really be resolved to keep going.
Thank you. I think I probably identify with the penguin pretty strongly from one of your previous slides with the curiosity and which way it's going. I suppose leading on from that, do you think that it's would you recommend kind of focusing on one big question or having side quests to sort of mitigate against a hypothesis not being wrong? And how can you tell if you're going down the wrong path, and how do you get yourself back onto it?
So, first things first, have a hypothesis, and that could be anything. In my field, it would be their blood pressure elevation runs in families. Maybe there's a genetic cause. We're going to set out to find the genetic cause, and aim one is to find some genes. Aim two is to work out how they're functioning, and aim three is to try and say, you know, might there be a therapeutic target here? You won't be able in a 3 year PhD to be able, or 4 year PhD to be able to develop a drug. It just isn't going to happen. But you could get a long way to working out whether a target is potentially viable. So, what would I do if any of those aims fail? I would have a plan A, B, and C for each of the aims, so that if plan A fails, if I don't find any genes for blood pressure, what do I do? Well, the questions I would ask myself is my power calculation true, or have I been over optimistic in what I could achieve, and what can I do to mitigate that? And sometimes that requires a complete change of direction, but mostly you can navigate away either by adding additional data and collaborating with other people, which is what I've had to do when my experiments didn't show anything. So gradually you build up a data set. So, for example, when I first was working in genetics of blood pressure, we were working on 1,500 families based on two affected siblings. It gradually became clear that it was better to work on blood pressure as a continuous trait than simply the binary trait of hypertension or not. So we started to work on populations, and our first success when we found 8 or 9 genes for blood pressure was in 2009. I'd found one previously called angiotensinogen in 1994 in the New England Journal. Another group had also highlighted that gene in 92, but otherwise there was not much progress. And then in 2009, we published a paper in Nature Genetics, which showed that using blood pressure and now up to 34,000 people and validating the findings from the first 34,000 people in another data set allowed us to discover 8 or 9. And then we went up eventually to over 1 million people studied. And we've discovered over 2,000 gene regions, which all adjust your blood pressure a little bit. Probably they're not all relevant in everybody. There may be subclusters. We haven't found a way yet of clustering those. But it's interesting to say that all the current therapeutic targets are amongst those genes that influence blood pressure. So curiously, by pharmacology or physiology or biochemistry, we have managed to identify therapeutic pathways that are implicated in elevating blood pressure due to the genetics. So what I would say is if you get stuck and really stuck, go back to your primary hypothesis and say, is this the right thing to do? Should I be thinking about it again? But if you do get a bit stuck, but it's not a terminal event, then you need to chart your way through subsequent aims with a series of perhaps refashioned, redesigned experiments. And that's where supervisors are crucial, because those of us who are veterans of this are used to this happening. And so for us, it's not so destabilizing. So we can provide the confidence for you to carry on.
Thank you. You mentioned the importance of identifying a mentor as well as a supervisor. Do you feel that kind of mentorship schemes are the best way to do that, or do you recommend personal mentors from people who you've come across, who you found?
Yeah.
And would you suggest someone within your institution or someone external to your institution?
So I think to answer the last question first, I would try and find someone that you know you get on with, who will be an unbiased and independent opinion. So they could be, if you know them from outside your institute, they could be that person, or they could be from inside the institution. It depends. It needs to be someone you trust implicitly, someone that you know will be a good listener and a sounding board. They're not directly involved in the science, but what they can do, Helen, is to say to you, you know what you're saying just there about this experiment, having listened to people talk about their research for some time, they can often detect when something's not quite right. And sometimes supervisors like I have got too close to the experiments and we're no longer seeing the wood for the trees. So we really sometimes need that extra little bit of somebody saying, this experiment here, I think it doesn't work because of that. Or the other thing mentors can do is they can give you great reassurance and encourage you to continue onward. So I would encourage anyone to get a mentor. They're not your supervisors. The supervisors, like you, are very close to the experiments are being done and sometimes mightn't be as objective as an independent mentor. Now, just to say, Helen, I've had mentors at every stage of my career. I don't really have one now, but I have had one throughout my life pretty much. It's really important. These people are hugely valuable to you, and I've always felt very happy to have a good mentor and to feel reassured. And occasionally they've made a huge difference to my career direction.
Fantastic. Do you mind if I ask a very quick question, which
That's
actually
fine, Joe.
from a very early on, someone asked me recently, some of my clinician friends have said, what are the differences basically between doing an MD and a PhD, those early on trying to pick projects, and what will it mean for me if I did want to, undertake more of an academic career? You
Yes.
to make a general comment on that.
So I have an MD. I suppose if I had my time again, I'd probably do a PhD. So an MD quite often is done alongside clinical duties. Um, but I would encourage everyone to have a dedicated fellowship to buy your time out. So, maximum, you're doing a day of clinical work a week because there's so much to do when you start, as you know, because you're doing it now and living it. There's so much to do, and it's got to be driven by you. And so, you really, really need the time to do this. So, I think in some ways, MDs and PhDs are very good, but that an MD is something we used to do alongside clinical practice, and this could often derail an MD. So I took several years to do my MD, whereas if I'd done a 3-year PhD, I would have been more concentrated. Now, I was fortunate because I got a New England Journal paper out of it, but that I was at it for 5 years by the time I got that. But that was flexibility to get an MD. Now, MD by research is also an important alternative for those who, for various reasons, can't take time out in a fellowship. But I would generally encourage a PhD because it gives you more dedicated time to focus on this. And as you know, Jack, yourself, and Helen too, the problem for us is that if the clinic calls, it's very difficult to resist it. So if you have a clinical problem on the ward or a clinical problem in the clinic, or you have someone turns up unexpectedly, you will stop doing your MD and you will go and see them, okay? Because that's what we're conditioned to do. And the problem with that is that you feel, as I would feel, that you cannot say no. And I think that's right, but you're not as protected in an MD as you are in a PhD. It's got a lot better, and most supervisors are interchangeable in terms of the way they look at how these fellowships should progress and how they protect your time, but not all. The other thing about an MD is it could be done in 2 years if you were really lucky. Now, there's a person who's recently done their PhD with me. Her PhD was meant to last for 3 years. She did it in 18 months. And that's your other supervisor, Jack, Emma McGowan. So,
Very good.
people can do this. Now, there are not, in my experience, having been doing research for quite a long time, there are not many people of that caliber about, but you can do it if you are absolutely focused. Focus is so important.
What I was just going to say is you showed at the beginning that the number of clinical academics is falling and the
Yes.
proportion of the workforce. How do you prioritise research with all of the other demands? And how would you recommend to someone coming through integrated academic training to balance their research alongside the multiple other demands that a clinical academic has to deal with
Well,
outside of the PhD MD situation?
so the integrated academic training scheme is designed to incubate the clinical academics of the future, going all the way from FY to clinical lecturer. And there are a number of stages, and some of us go through all of the stages, but most of us go through one or two of the stages, but not all of the stages, either through the happenstance of UKFPO or the happenstance of resident doctor training. So what I would do is I would in those component things. So for example, an academic clinical fellow should be 25% doing their research program, and a clinical lecturer should be doing 50%. And I would have thought when you come forward for that, you should have a discussion how the clinical week will work to facilitate you. Sounds like we've got a bit of feedback. Apologies.
Yeah, it's not.
So so when you do an ACF, you'll spend 25% of your time in research, and when you do a clinical lectureship, it should be 50%. It's important at the outset to know when that planned period of time comes through and what you're going to do in it to have a really good plan. So whenever you can, you're trying to input into developing the necessary outputs that will get you to the next level. But this is where supportive mentoring and individual supervision comes in. I see it as my duty to make sure that the people who put their faith in me are successful, partly because I'm interested in making sure there's somebody to follow after me, but also because I think clinical academic life, if you're successful and lucky, but also if you work hard, is a really exciting career. So, I just say this to you because sometimes young people choose just to do a clinical career. Now, just is not the right word because a clinical career is hugely demanding. And, you'll often be doing 7 programmed activities as a consultant in clinics or ward rounds or other things in a 10 PA job plan. And you'll be doing on call too. And really, there's no time for research. After you've done that for a number of years, the inquiring mind that everyone listening to this today has means that you're likely to have questions that you'd like to answer, but no time in which to do it. And so now, even in my hospital, we have a scheme where we can buy out certain people who want to do research but didn't have the opportunity, a day a week, so they can do some research. And some of them have gone on to get substantive fellowships and do higher degrees as a result. But you have to have a really supportive system in the places where you are training to make that work. Because if your supervisors are not helpful and supportive, there's no one to protect you, and you can get drawn into the eternal pressure that's on the NHS these days.
That's lovely. Thank you so much. Jack, do you have any further questions?
No, that's great. Thank you.
Well, I think then I'd just like to thank you on behalf of the AOP Early Career Researchers Committee. Thank you so much for an incredibly helpful webinar, and thank you so much for your time and taking the time out to talk to all of us. And I'm sure everyone who has the opportunity to listen to it will get a big benefit from it. So thank you so much. We really appreciate it.
No, thank you. You're the future, so it's the least I could do. So I regard this as a privilege and a joy to be here with you. And if it's been of any use to anybody, do always get in touch, and you can ask me any questions. If you've got uncertainties, I'm happy to help. Thanks both Jack and Helen, and thanks to the Association of Physicians for inviting me.
Thank you so much. That's so generous of you. Thank you.
No problem.